And really proud to be presenting with a great group of colleagues. We're going to kind of have a round table here, and it'll be a little odd. There's going to be some theatrics here. We're going to jump up and down. We're going to share different slides here. But it was really important for me and for the team here that we had a variety of different presenters, and not just one person presenting other people's models. But the idea today is going to be around diabetes. We're really excited. Centene is our parent company, a multi-line healthcare company now, a Fortune 66 with offices relatively nationwide from West Coast to East Coast. And was just earlier, right before the session, talking to one of our leaders and saying, honestly, within Medicaid, when you hear somebody like John speak during the keynote today, anything that happens within Medicaid now happens to Centene. I mean, we're really a proud provider of care to Medicaid beneficiaries, Medicare, commercial, and other lines of business across the country. So if something happens in Medicaid, it affects us. And so we started looking at diabetes. We realized there has to be a better way to do this. There has to be a better way to provide care to our diabetics, to provide care to members. As an emergency physician, I take that care very seriously. 1/3 of the members I take care of on a clinical day-to-day basis prior to the Affordable Care Act were uninsured, and now they're Medicaid participants. And so as me and my colleagues have been looking at this problem, we've realized Jeremy can't solve it, and Mike can't solve it, and Cathi and Jill, but together we believe at Envolve we're starting to slowly get a groundswell of support for how to change the paradigm in taking care of diabetics. You're going to hear about some of our programming today. I'll let each of my colleagues present themselves, but to say we've got an established and a very reputable group is understating it. I'm very, very proud to be here with these folks. We've got experts in pharmacy and in optometry. I'm a clinician, and like I said, I've been working with this team for several years on some of the programs we're going to talk about. Envolve Health is a new moniker for us. We took essentially 5 different companies providing anything from 24-hour nurse advice line, triage support line, care, dentistry, vision care, disease management, digital health care. We put it together under the umbrella called Envolve Health. And so, these 5 requisite companies, I think total probably 6, 7, 8, 9, 10 different companies now under the Envolve umbrella, primarily to provide services to our Medicaid members, which now reach nearly 15 million, 22 million total lives touched. And so when I say ripple effect, every program we create really has this incredible opportunity to bring care not just to the members of Mississippi or Missouri or California, but nationwide. And that's a great honor, a great opportunity, but a great responsibility that we take seriously. You'll see something up there called the Envolve Center. I was lucky enough to be a part of that. This is a joint operation between Washington University in St. Louis, Duke University, the Center for Advanced Hindsight, and Centene. And it's exactly what it sounds like. It's a center focused solely and specifically on behavior change science. We believe one of the first of its kind where a public-private partnership came together. Centene saying, hey, there's got to be a better way to take care of members. And these research institutions saying, hey, we've seen a lot of our white papers die the inglorious death of a white paper, right? You've got a researcher or PhD putting out great research only to have it die in a peer-reviewed article. And we said, we've got 15 million members that could benefit from this science. What if we fund research that is focused specifically on healthcare concerns and behavior change science? And then we give this science life in products, in programs, in services. And that's what we do every day. I tell my wife periodically, because she asks me all the time, didn't you go to medical school to be a doctor? What do you actually do? And while I'm trying to figure that out, I say, what we get to do is actually impact lives millions at a time. I really do get to be one of the luckiest guys, I believe, in the country, because we've got a center that is taking best-in-class science, applying it to programs like diabetic members, and the programs we serve to these diabetic members, and then tracking and trending that over the country and changing, iterating as possible to make sure we have best-in-class services. Not what we say is best-in-class, but truly best-in-class. So diabetes, why do we start there? It sounds somewhat pedantic or pedestrian or obvious, but diabetes is huge. And as I said, Centene's scale now is one in which when we have a diabetic problem, we've got a multi-billion-dollar problem. Billions and billions of dollars within our own company being spent on diabetes. And so we could have started on some kind of oncologic care program. We could have started on sickle cell anemia. We started on diabetes because it was huge, right? I'm not the brightest guy in the room. You guys have already learned that over the last 7 minutes. I started on diabetes because it's enormous. And I thought, man, I could have a 10-year, 20-year, 30-year career just building programs in diabetes. You look here, 1 in 4 people now at risk of developing diabetes. I promise you, every one of you in the room has a personal family member, not somebody you know, somebody in your actual family that has type 1 or type 2 diabetes. And so some of it is selfish. If we've got to create programming, why not create programming that affects a huge financial risk, a big bogey for us? But also, if we're going to create best-in-class programming, let's start on something that has a huge ripple effect. every 19 seconds somebody's going to be diagnosed with diabetes. So we're going to be up here for roughly an hour. There's going to be nearly 200 new diabetics. I mean, think about that. That's really brings it home. Over the course of this quick talk, 200 new diabetics. The spend's out of control, right? 1 in 3 Medicare dollars and 1 in 5 total healthcare dollars. And so if you look at the chances of this doubling, it seems very high over the next decade for this cost to double. We're all at risk, right? Everybody in this room is at risk for diabetes. And so we've got some of our business development folks here and people that I'm sure run health plans. And I've always said, hey, I don't know if the programs we're going to talk about today are best in class. We feel like they are. But honestly, if you do not have a solution for diabetes, you better get one. Because this is an avalanche, right? It's moving downhill very quickly. I call it the health snowball. And it's not moving in a positive direction. So if you do not have a solution for diabetes, have one. And if you do, we'd love to hear about it. Because we don't, like I said, we don't feel like we've got this mastered. We feel like we've got a really good line of sight on it. So we're talking a little bit about data and how important it is. You heard a really wonderful keynote. I don't know if you guys were mesmerized like I was, but hearing him talk about the power of data and how he thinks artificial intelligence and predictive analytics are going to play a heavy role in the future. Really, I mean, Mike and I were meeting for breakfast, and it's exactly what we were talking about. I hope you won't think it's ridiculous to state this, but we really do believe in some of our programs, particularly a program Mike and I are going to share a little bit around On.Demand. We really do feel like we're starting to predict the future in our diabetic population. And that's interesting, but it wouldn't be that interesting if we weren't changing the future. And we've got a testimonial, and we'll share a little bit about some specifics, but we have real storylines where we have predicted the future minute to minute in advance of an event, intervened with one of our care managers, and we think changed the future. And that's exactly what he's talking about. It's the power of not just data, the power of actionable data. But to be honest with you, any insurance company has claims data. And as I bring Cathi up, it's really important to understand that data alone isn't the answer, right? And certainly claims data alone isn't the answer. And so as we share through pharmacy and optometry and our disease management programs, I hope you get a sense for how we're taking data and applying it, intervening, not just after the fact, right? After a big event has taken place, but in real time.
Thanks, Jeremy. So I'm Cathi Misquitta. My team at Envolve Pharmacy Solutions oversees our clinical programs, and I have a team of pharmacists who work one-on-one with our patients and help them understand medication adherence. And like many health plans and PBMs, when we originally started identifying members who were non-adherent to their medications, we calculated their proportion of days covered, or how many days did they actually have medication in hand that they could be taking it. And the definition for being adherent to their medications is having it 80% of the time or more. Well, when we actually talk to the patients, and this gets back to what Jeremy was saying in terms of claims data alone is insufficient, we found that at least 20% of the time we were identifying members who appear to be non-adherent because of their claims data, but in actuality were taking some medication. Now, it could be because their dose had changed. It could be because their medication had been discontinued by their physician and switched to something else. It could be because they had a span of time in the hospital and the claims data is so far behind that we weren't able to see that on the pharmacy side. So we were misidentifying some patients. And the second point I wanted to make with this slide is really on the side where it says true non-adherence. And this really illustrates how there is no magic bullet to improving medication adherence, and that we look at broad populations, but it's really the individual person that we must impact and see that behavior change, because there are a ton of different reasons why someone may not be taking their medication, and I won't read the list here, but this is just a few. And I will note that I think knowledge deficit I have there listed at the bottom. It's probably our most common, but even that we maybe only see 15 to 20% of the time. Our largest category when our pharmacists are trying to categorize their phone calls with these patients is other. Because even though we have tons of drop downs and categories from which they can choose, there are so many calls where we really can't categorize it. There's something else going on that we can't notice. So again, claims data isn't the only answer. So I'm going to hand it over to Jill, who will talk a little bit more here.
Hi, I'm Jill Scullion. I'm an optometrist with Envolve, so I'm going to throw in a couple little vision stuff here. So adherence to preventative diabetic eye examinations in the United States is approximately 42%. So due to the possibility of vision loss, this HEDIS measure aims to prevent avoidable blindness through early detection, intervention, and creating the opportunity for patient education at the hands of the provider. Last year, 66% of the diabetic members at Magnolia Health Plan were compliant for their diabetic eye evaluation. Although this exceeds the national average, there's definitely room for improvement here. So our opportunity is to educate members of the importance of this preventative measure and the consequences of foregoing this measure. Without this knowledge, the member may not understand that diabetes can cause vision loss with relatively few symptoms in the early stages of diabetic eye disease. We've also found through claims analysis that some diabetics actually did go for an eye exam in the measurement period, but found it irrelevant to disclose their diabetic status to the eye care provider. After chasing these records, we often find that the eye care provider did not find it necessary to do a retinal exam. Therefore, the member's diabetic retinopathy status remains unknown. Okay, so I'm going to hand it back over to you here.
So you get a sense for, like, you know, the terrible issue of a member, right? Meaning you got a member, and I'm worried about their inpatient rate, their ER rate, because I got a CEO calling me saying, Corbett, these diabetics are costing me $15,000 a year. But there's some quality czar in that same exact health plan worried about their diabetic retinopathy screening, right? So I've got a care manager calling this person, talking about their ER utilization patterns and their insulin utilization. And I've got Jill's team calling about retinopathy, and you get phone fatigue, right? You get these multiple different calls, and we can't quite figure out why we can't get these members to move down the right pathway. It's the same reason I wouldn't take 50 different calls from the same company. I'd say, what are you guys doing over on that side? You know, we've got to have an integrated we've got to have an integrated model. And so it's taken us a while as a big company with 30,000 people to get us at the same table to figure out how do we approach member care, because at the end of the day, healthcare is extremely intimate, right? Extremely personal. And while I'm a big fan of AI, I am not personally a believer that we're going to move all of our healthcare to AI, right? Because honestly, you look at telemedicine, for instance, there's tons of data that shows you operate telemedicine or give it to a company, and while telemedicine utilization will go up, primary care visits don't go down. People don't substitute telemedicine for their primary care intervention. They augment it, right? They use it for those in-between visits. And so we've got to actually have what I call IAI, right? Intelligent artificial intelligence, making sure we reach every member and then maximize that intervention, that time we have on the phone, or through chat, or through some kind of asynchronous chat, to get the retinopathy screening done, to get their medication adherence up, and also to get them to stop using the ER if there's a better source of care for them. So honestly, I say this very, very humbly, that we and the team I ran were doing a really bad job with care management, to be honest with you. I was lucky enough to run a disease management company. The legacy company was Nurture. And while we have incredible men and women doing their job, we were doing the equivalent of the horse-drawn carriage mode of transportation. So you think about Henry Ford in 1908, he revolutionized transportation, right? He didn't go out to create the faster horse. That's what he always says, right? If I listened to my customers, I would have given them a faster horse. He redid transportation. And I promise you, he was hearing a lot of naysayers during that time period, right? You see, people say, this thing's going to leak, this thing's going to break down, this thing's expensive, it's loud, it looks ridiculous. And he didn't care, right? Because he knew, and his vision was way out in front. I'm going to revolutionize transportation. I have this sense, and I don't know, but I bet a lot of the naysayers were horse breeders, right? And carriage makers, right? They had people who had a lot to lose by revolutionizing that industry. And I like to believe that because honestly, we were doing it this way. And many of you guys are as well. And honestly, in many of our markets, we're still doing it this way because we're a big company and we have to slowly move 28 different health plan CEOs along in this new model. But we were identifying people with claims data and we say, wow, this guy's really expensive. I bet we better put him into a care management program. And then we try to outreach, right? And good luck, right? In Medicaid, trying to get these members. I remember one time I asked Chris Baker, she's not here, so she can't defend herself, but I said, take your next 100 calls. She was just a case manager in my little health plan in Lexington, Kentucky. I said, I want you to actually write it on an Excel spreadsheet, how many times you get a member out of 100 calls. And she came back the next day, 6. So she took 100 units of energy and reached 6 members. Awful. So is there opportunity for AI to play a role? Absolutely. But once you get one of those 6 members, you got to engage them. You got to have a storyline that makes sense, right? They're dealing with parenting issues and childcare issues and job issues and transportation and housing, the social determinants. Good luck engaging them unless the storyline is great. Then you have to get them through a program, and if you do that and you measure the outcome and it's successful, you try to rinse and repeat it. And that's what you call a life, that's what you call a career, that's what you call a program. But it was the best we had, it's all we had. So we started looking at it, we said there's just got to be a better way. I don't know if it's going to be better, but it can't be any worse than this because this is antiquated, right? It's a horse-drawn carriage. If we went out to lunch after this, I'd like to, by the way, if you guys are interested, and we got in a horse-drawn carriage called up by Uber, you guys would all laugh, but honestly, it would get us, right, to farmers and distillers eventually, right? It just wouldn't be effective, it wouldn't be fast, it wouldn't be efficient. And you guys would say, what, there's a better way to do it, Corbett, but it's not ridiculous. In much way, this isn't ridiculous. I just think there's a better way to do it. And so we call that better way to do it on demand. And the idea was, hey, there are glucometers out there that are not Wi-Fi or Bluetooth. They are cellular. Our Medicaid population is just like us. I share a story I'm from Lexington, Kentucky, and I went to the Louisville Metro Public Health Department about 3 years ago, and I got out of my car, and it's a used car, but it's a reasonable looking car, at the exact same time as a bus unloaded, okay? So I got out of the car to go into a meeting with the Public Health Commissioner in Louisville. And as I got out of my car and was walking into the parking lot, about 15 to 20 people got off the bus with their children by themselves to go into the Public Health Department. Do you know what we all did at the exact same time? I would love for somebody to get this right. What do we all do? Yes, Marianne, exactly. We picked up our phone, right? We do it, we just unconsciously pick out our phone. What was interesting, though, and I'm so glad I took notice of it, every single person picked out their phone. They took out the same phone I had, which is very interesting. Think about it. They didn't have transportation by evidence of getting on a bus, right? They're getting their primary care at the Public Health Department, which isn't where I was getting mine, but yet we all got out the same phone. I thought, man, times really are changing, and if we at Centene are not ahead of that game, if we're playing catch-up, we're going to miss this. So on-demand is really simple. It's not elegant in any way other than its simplicity. We realized there were cellular glucometers out there, and I said, hey, Mike and your team, would you guys take a ride with me here? If we traded out your benefit and said, you know what, the traditional benefit is no longer the benefit, and now the benefit is these brand new cellular glucometers, and we harness that data from the cloud, okay, on Amazon Web Services, same thing everybody else is using, and we disrupt the supply chain. And we now mail order test strips to our members, who, by the way, have transportation issues, who, by the way, have child care issues, who, by the way, don't like going to the pharmacy like I don't, and we mail order, drop ship their test strips rather than them going to the pharmacy. Let's just see what happens. Would you be game? And Mike and his team and his CEO, very wonderfully, like many of our CEOs, said, heck yeah, sounds better than what we're doing. What are you going to do with the data? I said, well, long term, I'd love to intervene on these members in real time. That's my goal. But right now, let's just track and let's see how many people yell at us and how many people curse at us and how many people opt out of the program. And what we found is absolutely the opposite has taken place. We deployed about 4,000 glucometers. We still think it's the largest single geography mobile health population pilot of its kind in the country. And we're starting to track data across the country. Halloween is actually tomorrow. I didn't think about saying this, but last Halloween, we found that the average glucose score across Mississippi went up about 15%. From noon on Halloween day to noon the next day. Why? They were housing their kids' candy like I'm about to do when I get home, right, tomorrow, right? So it's funny, our members are just like us. Last Labor Day, my data team came and said, hey, Corbett, we're getting data pulls from all over the coast of Florida, Panhandle all the way down to Tampa. I think something's going on with our data because we pull base station IDs. These actually have Verizon chips. They're cellular devices. I said, man, that's not great. Let's dig into it. And one of the very, very common sense people on our team said, you idiots, they're on vacation, just like we're on vacation. They were taking their glucometers, our Medicaid members, on vacation. I realized, they're not that different than what we are. We think they are, but they're not. They use the same devices. They have diabetes. They travel like we travel. And so we're finding that, honestly, population health for us is now not subpopulation health. That's this, guys. This is subpopulation health. It's taking data, right? Taking your top 5-6%, putting them in programming and calling it a day and saying, we've got diabetes population health. We've got hypertensive population health. We've got CHF. And we said at Centene, that's what we've been doing for a long time. Now we're not. If you have a diagnosis of diabetes at Centene over the next 24 months, you will have this device. If you have diabetes anywhere in the country, you will be in the program. And that takes a lot of collaboration. I mean, Ross back here is probably sweating, our CMO for our pharmacy solution, because we've got to actually change benefits in all these different states with all the regulation. We've got to deploy mail order pharmacy across the country because we believe the power of data is so imperative and so important. It's now imperative for us to actually have a solution. This is what a traditional DM looks like. We were enrolling about 5%, not of the population, of our diabetics. So I already told you, we had a multi-billion-dollar diabetes problem, and yet 5% of our diabetics were in our program. Why? Because we only had that many coaches. Our health plans had only signed up for that much service. So I said, hey, take the dollars off the table. What if I can deploy a program that gets 100% of our identified population for the same cost? CEO, would you be up for that? And he goes, well, of course. She said, of course. How are you going to do that? Honestly, I think if we actually have our care managers intervene on those who need intervention, not on those who we think need an intervention, we can do this. So the glucose data is available to an entire care team. It doesn't matter if it's a case manager at the health plan or a disease manager sitting in the central office. It doesn't matter if it's a quality leader saying, hey, I want Corbett, every single diabetic in Mississippi who's got a trending A1C over 9. Think how powerful that data is. We take the average glucose score from these devices, we back into a trending A1C, and now they have every 500 or all 500 members who have a trending A1C over 9 for quality. Able to make the data actionable is where this is novel, not having the data. The intervention is real time. Our first story was December 28th. It'll be seared in my memory, I hope, my entire career. So December 28th, I was on break like most of us. I was sitting up in my kid's playroom, and one of my kids was working on a really annoying puzzle. I remember at the time, we'd been trying to solve this thing for like 2 hours, and he would not get it go, or let it go. I got a call from Kelly Cash, one of our managers, and she goes, she's crying on the phone. So this is a woman on her vacation who's crying. I said, hey, Kelly, what's going on? And she goes, honestly, I just got a call from a coach in Mississippi. So a coach working on Michael's health plan. And she goes, she just made the first on-demand call. So we've been tracking data. We've been disrupting the supply chain. At that point, we had driven down test strip fraud, waste, and abuse by 60%. Why? Because we weren't sending test strips to people who weren't testing anymore, right? If they tested, they got test strips. If they didn't, they didn't. And she called and she goes, let me tell you about the story. She goes, Joanne, for the sake of the story, got a reading of 455. And in our system, we call it the launch pad, it alerted red. So Joanne, the coach, said, wow, I need to call Cathi, this member. Called Cathi on the phone and said, hey, Cathi, what's going on? I saw your sugar was 458. And Cathi, after being terrified by the phone call, said, how did you find out? Oh, that's right, my device is connected. Yeah, my sugar is high, but, have no fear, I feel fine. And Cathi told Joanne, hey, to be honest with you, it was high yesterday as well. Well, Joanne didn't know that because the launch pad had just turned live that morning. And she goes, well, what did you do yesterday? She goes, I went to the ER because I can't get any insulin. My pharmacy benefit is messed up. Went to the pharmacy, couldn't get insulin. I don't know what to do. I feel fine, actually. I had to go to the ER. And the ER doc kind of gave me the riot act for showing up for insulin, right? Here's an ER doc, me, right? Saying, what are you doing here? Your health plan can't even figure this out? Do you know this visit's going to be $2,000, right? For a couple dollar shot of insulin. She said, to be honest with you, my husband's pulled up in the driveway. We're about to head back to the ER because I don't know what else to do. And Cathi and Joanne solved it on the phone, right? We got an emergency override that day at the pharmacy and did what any health plan would do, right? They got the pharmacy benefit fixed rather than sending this patient to the ER. So I asked Kelly why she was crying. She goes, honestly, because the coach told me I am finally doing what I signed up to do. I'm intervening and changing the future. I'm not calling people saying, hey, Cathi, I saw you in the ER 3 times last month, right? These are clinicians. These are care managers. They're actually doing care now. And so I'm really proud of actually putting at our fingertips, right, our coaches' fingertips, actionable data. It's not novel. This isn't rocket science. The data is available. We just created a launch pad, an interface, if you will, and then told our coaches, stop using the calendar to call. Call that 5% not who are enrolled, the 5% who need help today. And that's what we've done. So we have all kinds of cues. If we ship a glucometer and they don't turn it on, activate within 5 days, they get a call, right? They're not even engaged in the program at all. So now the call isn't, hey, Marianne, how are you doing? Hey, Cathi. It's, hey, on Tuesday last week at 5:05, we have a FedEx delivery. You got a device. Why haven't you turned it on? Well, it feels like Big Brother. I didn't know what it was. I'm technology averse, whatever it is. And they can solve that problem rather than the overall diabetes. Let's say Michael in this example is checking every day at 10 o'clock in the morning, 2 in the afternoon. Okay? So he checks his glucose, and his glucose is great. 10 and 2, 10 and 2, 10 and 2, 10 and 2. And suddenly for 2 days, he doesn't check. And I can look and say, man, this guy's also got, Michael doesn't, by the way, but severe mental illness, right? And he takes an atypical antipsychotic. Do you think that's data my behavioral health team would like to know, that he's compliant in glucose, compliant in glucose, compliant in glucose? It's a proxy, right? It's not real. I don't know if he's not taking his, but somebody who's not compliant is usually not compliant across the board, right? Somebody who's compliant is generally compliant. Isn't that actionable data, not from a glucometric standpoint, but from a behavioral health standpoint? Do you think my behavioral team is ecstatic about having that data? But it's glucose data. Jeremy, yeah, I know, but isn't that better than what we currently have? Smart education. This one is really funny. My team thinks it's hilarious that this is novel, but it is. We have generally, and this is again looking in the mirror and saying, very, very vulnerably, we were not doing things well. We were horse-drawn carriaging it all day long. We just sent glucometric education, right? So I actually just saw it, Marianne, I just saw it last week. I got our approval for this Q4 mailing that we do for diabetics. And it had like a pumpkin soup recipe, which has been the example I've used for last year. And it was funny. It actually did have a pumpkin soup recipe. Hey, it's fall, and you got diabetes. Here's a low sugar. Well, kind of cute, kind of funny, but not that helpful if somebody's not even checking their sugar, right? Why are we sending them recipes that they're not going to use? Why not send them education based on where they are? If they're not even checking their glucose, let's send them education around the importance of compliance. Let's not even talk about glucose. If somebody's checking their glucose and they're in compliance, let's not beat them up about recipes and exercise. Let's send them attaboys, right? Now we can send education, print mailers in the mail that is focused on and infused by real-time data. So our data is actually affecting our old school print educational materials as well. We obviously triage, monitor, and coach based on the data as well. And to bring it home, I mean, what we're finding now is that our coaches are more engaged because our members are more engaged. We already had, in my opinion, best-in-class behavior change coaches. These men and women were really good at what they did. They signed up with Centene because they wanted to impact 10 million at the time and now 15 million members with their clinical knowledge. But what we were giving them was a really, really crummy toolkit. We were saying, here's the trans-theoretical model, right? Here's some motivational interviewing techniques, and here's some data that is 3 months old. If you guys flew in yesterday like I did, and I was jumping in my Uber and it was dripping wet, and I was wearing shorts and a t-shirt, you guys would have said I was an idiot, right? I have a phone that gives me the weather, right? But what if I told you and I got out of the Uber, well, I wore this because I looked at a newspaper clipping from the Washington Post from 3 months ago and I dressed accordingly. You say, again, you're an idiot, Corbett. Now, you guys might say I'm an idiot anyway, this is fine. But honestly, why would we use 3 months old data to dress? But yeah, that's what we've been doing for a long time, guys. We're using 3 months old claims data and making interventions today. And that's when I finally got the attention of my leadership at Centene. I said, I wouldn't dress for the weather 3 months ago. Why are you asking me to intervene on my diabetics based on data that's 3 months old, right? They said, aha, yeah, let's intervene on the data that's today old, seconds old. My sugar is 458. My husband's about to take me to the ER for insulin. We predicted the future and changed the future. And the end of the day is, medicine, as I started with, is extremely personal, right? It happens member to member. It happens clinician to member. It doesn't happen at a macro level. I get to make programs at a macro level, but if you do not have that person-to-person intervention, that person-to-person engagement right, you can forget about all the modeling. You can forget all the sexy programming. It doesn't matter, right? It doesn't matter if you don't get that personal piece right, and we're going to share a little bit more about that now.
When we talk to our patients about medication adherence specifically, or changing their behavior, kind of the old school way of doing that was giving the clinicians a scripted survey, so to speak, of questions where they could use, talk to the patient, are you having trouble taking your medications? What time of day do you take your medications? Are you having any side effects from your medications? Do you have trouble getting to the pharmacy? And what happens is that laundry list, barrier analysis doesn't feel personalized, right? It's hard to develop a connection with the patient when you're talking to them that way and trying to get information and then trying to solve their problem. And it becomes very paternalistic. And maybe that will work with some patients, but honestly, it's not the majority. And if you think about how you would want to be treated as a patient, you would want someone to listen to you. And ultimately, if someone is telling you what to do, it's not necessarily going to change long-term behavior because it's ultimately up to that patient, that member, to test their blood sugar, to take their medications, to be responsible for their own health. So Jeremy briefly touched on motivational interviewing. I just want to talk about that a little bit more because rather than using something that's scripted, we use something that is much more conversational with the patient. We start with open-ended questions. How are you doing on your medications? How often do you think you miss a dose? And when they respond and say, well, I don't really think I miss my medications more than once a week, and we say, may I share with you some information about that? So now we're asking permission to talk to them. And when they say yes, now they're already starting to be open to how we're going to give them information. And so we say, well, when you miss one dose a week over the course of a year, right, 52 weeks in a year, that's almost like missing 2 entire months of your medication. Oh, I never really thought of it that way. Now that you're thinking of that way, do you think, there's something you might try differently? And so we start putting the ball in the patient's court and the member's court to be thinking about what's important to them, why might they want to take their medication and test their blood sugar and be more adherent to their regimens. We use a lot of reflective listening. I hear, and we speak back to them in our words what they said to us to make sure we understand where they're coming from. And this rapport builds trust. Being very member-centric, listening to them, what's important to them, and then what can they do for themselves, and then holding them accountable for that and following up with them is really where we start to see behavior change. And so this slide really just talks about some of the various components of motivational interviewing. So again, we're not talking about a script. We're talking about showing empathy, collaborating with the patient, what would work for them, getting their suggestions on things, understanding their perspective, and ensuring that we are supportive in what they want to do. And all of that really builds trust, and that's especially important when we're calling members, when we have clinicians who are doing telephonic-based work who, they're not their neighborhood pharmacist, or they're not their, personal physician that they're talking to. So these are people that they may not have even met before. And the last one I think is the most important, which is evocation. Getting the member to talk about what could they do differently, and then, all right, so you said you're going to use a pill box from now on to remember to take your medications. Can I call you in 2 weeks and see how that's going? And so when the clinician's following up with the patient, then there's something targeted that they can talk to, and it's a quick conversation, but it helps solidify that change. So with that, I think I'm going to pass it back over to Jill.
Okay, so back to vision. Unlike the On.Demand phone program, we don't really have a neat little device that patients can put in their pocket that's going to allow them to check the status of their diabetic eye disease. So because of this, Envolve piloted the use of its mobile eye examination van that we nicknamed Seymour for the diabetic outreach purposes. So Seymour's main objective has been to support corporate social responsibility efforts. Since the program was launched in May of 2015, Seymour's traveled over 50,000 miles and provided vision services to over 11,000 community members. So Envolve repurposed the goal of the van to develop a pilot mobile diabetic eye care outreach program to increase diabetic eye disease detection, intervention, and education when transportation was identified as a barrier to obtaining care. So the success of this pilot identified the need to expand mobile vision services in a more scalable way. And so as previously discussed, early diabetic eye disease comes with relatively few symptoms. So for those members who are able to travel, how do we motivate them to participate in this evaluation? Well, we can continue to perform the member and provider outreach calls, but how can we create a scalable model that doesn't require this administrative burden? Well, we can offer them an enhanced hardware benefit, because eye care is a little bit different. You've got that touch of style thrown in. There's the whole process of choosing your glasses, trying on different frames, and then finally determining what your insurance is going to cover. So offering our members a great hardware benefit motivates them to participate in an eye exam, as there's a reward for doing so. The member is satisfied with their glasses, and we've created the opportunity for diabetic eye disease detection, intervention, and member education, hopefully leading to better outcomes and decreased progression rates to vision-threatening diabetic retinopathy. All right, so moving on to results. Through these interventions, what has Envolve accomplished? So, using the eye care claims data, we show a slightly decreased prevalence rate of diabetic retinopathy within the Magnolia Health Plan compared to the national average of 28.5%. However, although the prevalence rate of diabetic retinopathy is lower than the national average, the percentage of members with vision-threatening diabetic retinopathy is higher, indicating that within this population, many members are increasingly vulnerable to vision loss as a result of advanced diabetic eye disease. So changes in these metrics are not going to happen overnight, but through continual and ongoing focused efforts, we can alter these outcomes hopefully over time. Now, these metrics are pretty important because the average annual cost of vision care for a diabetic member with retinopathy is 5 times more expensive than taking care of a diabetic member without retinopathy. By providing a patient incentive, patient education, and removing barriers to care such as transportation, eye care costs can be controlled. We hope to expand our pilot mobile eye care program through a scalable way that engages our network of providers to reach those members who are unable to travel. In addition, we encourage the extra spend on an enhanced hardware benefit to encourage member engagement and provide the opportunity for earlier detection and intervention. So by combining these vision care specific efforts with motivational interviewing, we expect a gradual improvement in retinopathy detection and hopefully the opportunity to intervene before the member's sight is at risk. Back to you.
Yep. This slide is really just to, again, we're talking about results, we're talking about outcomes, and as the pharmacist and one of the pharmacists up here, my big goal is to see, is what we're doing making a difference? And when we started some of these programs that we were doing on medication adherence with the pharmacist making calls to patients and using motivational interviewing as a technique, what we've seen now since we started, I think back in 2012, is year-over-year improvement in our medication adherence in various lines of business across various classes of drugs. And so it seems, according to the data, that it's actually working and patients are actually taking their medications. So that was the point of this slide. And I think now I'll turn it over to Michael to go over some more specific results for Magnolia.
Thank you, Cathi. So, my name is Mike Todaro. I'm also a pharmacist. I live in Mississippi, born and raised in Mississippi, Biloxi, Mississippi, actually. Anybody ever been to Mississippi before? Wow, awesome. What? No. What do you know about Mississippi? What do we have a lot of in Mississippi? Anybody? We have a lot of humidity. You can jump up in the air and get stuck. We also have a whole lot of fried foods. If you come to Mississippi and you don't eat fried catfish, you don't eat fried chicken, you really have wasted a trip to the Magnolia State, I promise you. So with those things, we have a lot of diabetes. We have a lot of obesity. There's not a lot of things that Mississippi's number one in. We're not number one in football. We're not number one in education. But we kill everybody else when it comes to obesity, illiteracy, diabetes. There's a lot of things that we're not really proud of, but from a healthcare provider standpoint, there is a tremendous opportunity. So anytime anyone mentions the word diabetes around me, my ears perk up. For all the reasons that we've already talked about, there is a huge challenge for Mississippians and diabetes. Not just diabetes, we're some of the things we really have focused on in Mississippi are cholesterol, the asthma, a lot of the really chronic diseases that cause problems for Mississippians. But for diabetes in particular, we realize that this is a health literacy thing. This is things where we have an access problem. There is a map that I could have showed you guys that shows the Mississippi Delta, how there is one endocrinologist in around every 360 miles, which is a problem. If you've got a disease state that is predominant in a state, but you don't have any experts to treat it, you've got to do something. So we've heard all this cool stuff about technology, about intervention, about pharmacy adherence. So when all this kind of information trickled down to me and there was discussions on, hey, Mike, should we look at doing something like this in Mississippi at Magnolia? I was like, absolutely. Let's take a good look at it. One of the things that Jeremy and I talked about this morning and that was touched on in the speakers is managed care has a very low tolerance for risk aversion. They just don't. It's one of those things that you scratch your head about, but for us, we really don't have a choice not to take a risk on something like this. So when the information was presented, like, look, let's absolutely do this. Let's see what we can come up with. We've got some engaged case managers. We know we have a cohort of members that this is going to be a problem. So when we put this into place, one of the major things that I really wanted to get out of this was, how well is it going to work? The two things that I was hoping to see is, number one, are we going to make things better for our membership? Are we going to improve outcomes? The second thing is, how's this going to look from a financial standpoint? Are we going to be able to save any money? And really and truly, truth be known, I wasn't hoping or expecting both of those things. If we could have improved the way that we take care, we could have improved outcomes and spent a little bit more money, I was okay with that. And conversely, if things stayed the same from an outcome standpoint, but we were able to save money on some of the test strips like Jeremy talked about, that would have been a win too. But what we saw was we had this enormous misuse of our test strips because we have a lot of people that are remote, we have a lot of people that live in rural areas, and so they go and they get their test strips every single month. They don't use them. They don't understand how to use them. And so we were spending a tremendous amount of claims volume on these test strips that were never getting used. What we saw a 27% decrease in test strip. We also saw a decrease in utilization by 29%. And then you say, like, oh, well, they're not testing. Well, that's not true. They were testing, but they were testing it the way they should. There was education around the meals that they eat, the way that they change their drug therapy. And so what we saw was they started utilizing their test strips the way they're supposed to be utilized because it was real time. It's just like Walmart. When, Walmart doesn't go and order, they don't walk the shelves and count and see how many shelves of items they have. Every time you go to the self-checkout and you scan a barcode, it's triggering exactly how many they have, and it knows when to reorder. This is the exact same process, to where those patients, they don't have to worry about when they need to go to the pharmacy and get another one. Something's doing that for them. So the second thing that we saw was from a clinical side. Okay, well, we're saving money on all these test strips that we knew we had a problem with. How about the outcomes? Well, our decrease in glucose levels was, again, beyond what we expected. We saw a decrease in utilization, or a decrease in glucose levels, because this educational component, that health literacy that Mississippians struggle with, was really being worked on as they needed it and in a specific target population. That's the other thing that I really saw that was a huge win for this program, was we weren't just sending our case managers out to talk to all of our diabetics or even a portion of our diabetics. We were able to look and see the ones that were really having a problem, the ones that were consistently having these 400 tests, and talking to them as that happened. Hey, what's going on? Help us understand. Is it a pharmacy issue? Is it a communication issue? Can we get you a doctor's appointment? So it wasn't surprising to see this glucose level go down. We didn't expect it to happen as fast as it did. The compliance was the exact same way. Again, we saw that there were a lot of members that just didn't understand how they were supposed to take their insulin, how they were supposed to take their sulfonylureas. And once the diabetic educators were working with them real time, they understood it. They started doing it. They started taking it more. And so our compliance numbers went up. That started equating to some real statistics that looked for cost savings. We saw our ER utilization go down in this cohort by 15%. Because they were using their insulin properly, because they were keeping their blood sugar controlled, they didn't need to have these trips to the ER because they had access to go get their drugs. They had an understanding of what to do when things went wrong, and that was something that we were missing out on beforehand. Same thing with we saw with our specialist visits. The primary care providers had access to this information as well, and so they didn't need to go and see the endocrinologist. They were being maintained. So again, what we saw was benefits that trickled down because of that health literacy and because of that understanding that came from targeting the right education to the right members. So we kind of did this again in a multitude of ways. We've heard from a great group up here on how every kind of piece of this was programmed in, whether it's the technology side, whether it's the expertise from the diabetic education side, whether it's identifying what the problem was and making sure we're putting it in the right place, using all these things to help influence that medication adherence. Jeremy told a couple of stories about some case managers, some big wins. I could tell you numerous stories from being, in Mississippi, how this has impacted, how many wins we've had. But rather than me sit here and talk to you more long-winded about how things that I've seen, we have one of our members in Mississippi, Miss Lydia, who is a perfect example of how this program works, and she's going to tell you how this works in her own words.
Years ago, I went into a diabetic coma that nearly took my life. My sister took the picture of me in the coma. She was afraid that it was going to be the last time she was going to see me alive. I was in a coma for 9 days. The doctor that I was seeing told me, Lydia, without insurance, there's nothing else I can do for you. And I don't know what to tell you.
Lydia's diabetes was pretty uncontrolled.
I don't know what to say. I'm just so happy to see you.
We have members that use the Genesis meter that is a part of the On.Demand program. And through this program, I came across Miss Lydia's numbers because of course she alerted with something too high or too low, and it was repeat alerts. On.Demand is a real-time monitoring program that is for our Magnolia members. It's a new pilot program we started this year, and we get to monitor our members' blood sugars as they test them.
On-Demand is where they call you on the phone. They become part of your family and helping you take care of yourself. It doesn't matter what time, day or night, 24/7. There's somebody on the other line to help you.
What will happen is when a member tests their blood sugar and it's too high or too low, we get an alert on our portal, and we are able to address that high or low by calling them up and saying, is there anything that might have happened that might have triggered that blood sugar to be high?
I love the fact that you're looking over my shoulder at my numbers when they come into you and be like, all right, Miss Lydia, what's going on?
Well, if someone has a blood sugar that's low, I need to call that person pretty quickly and say, hey, did you treat for that blood sugar?
I think back in my head and remember what I looked like and how I felt laying in the hospital bed.
Oh my goodness, you were very, very, very sick. We taught her all those different methods of how to be more proactive with the blood sugars, fixing it before the problem happens instead of chasing a high or a low. The 157 is a good number, knowing exactly what you had for breakfast.
If it weren't for On-Demand, I don't think I would be as controlled with my blood sugars as I am. Having the On-Demand and Amanda on the other end of the phone has been a lifesaver.
Thank y'all so much.
That's it.
Any questions?
And if you do have a couple minutes, there are a couple of questions, sure.
Yeah.
One question that I have is, could you talk a little bit about the engagement method that you use? And what I mean by that is, when you're engaging with these, with your members, is it predominantly telephonic, or is it in person? Can you shed some light on that?
Yeah, it's funny. So I think the Mississippi pilot's an interesting pilot. So it's funny, this stuff needs to be redone because now it's, a full run program for us, for Centene. We literally drop shipped meters without any provocation, without any communication, partly because it was a pilot. We wanted to test what the response would be. And so I would say from a communication or engagement standpoint, you would do things differently, right? Appropriately. Somebody would walk out, Miss Lydia would walk outside, and there's a box that says, welcome to the Magnolia On.Demand Diabetes Program. And inside's a welcome card, a new meter, test strips, and a number to call her coach, Amanda, if she wants to engage. Well, that's neat, it sounds great, but that's not the way you would actually reach out to people. Our disease management program is primarily still telephonic, but not because of technology issues. It's because most of our members still desire. What we are now is essentially communication agnostic, and so we have the capability to provide asynchronous chat or texting or telephonic, depending on where our members are. And so I told you I was talking to one of our leaders today. He said, honestly, AI isn't scary to the 25-year-old diabetic in a way that AI might be concerning to Lydia, right? Based on age and demographics. And so Envolve has had to evolve from a communication Envolve has had to evolve from a communication standpoint. So right now our coaches can communicate through whatever channel or medium our members desire, but honestly most of that is still telephonic just because of the members we serve. Does that answer the question?
Yeah, and I guess just a follow-up question to that, which is around the telephonic. Do you see that is favorable, or do you see any kind of problems with communicating with a traditional telephonic case
Absolutely. And so, in fact, we have our business development folks here. It's funny, we developed this program for Medicaid. We're a Medicaid company, very proud of it. We certainly have now a growing book of Medicare and commercial business, but we're a predominantly Medicaid company. And I keep saying, maybe on deaf ears, if you can innovate a program that changes or moves the needle in a Medicaid population, it is exponentially easier in the commercial space, right? I think of those of us that are innovating in the commercial space for a Dell employee and trying to bring that to Medicaid, good luck. So the answer is yes. We found this on-demand program was created for Medicaid, and what we found now is our business development team is selling this exact same program to commercial clients. They're saying we don't have anything close to this, but what they're changing is we can't do telephonic calls. Our members aren't going to take telephonic calls. They have to have text. They have to have. So yes, we have found that based on the market we go into, the communication strategy has to change, but we don't deliver the communication we desire. The members pull communication the way that they desire, and that's what has changed from a programmatic standpoint. Early on, it was, you want this? Our coaches have a launch pad or a dashboard. They're looking and they're calling, and now the idea is, hey, if you think about where the future is with Amazon, right? Isn't an Alexa Echo far cheaper than my Amanda Care Manager? It is. I can't get rid of it. Amanda's critical. Look at Lydia's not going to put an Alexa in her house, right? Lydia wants Amanda. But there are members who would say, hey, for $179, yeah, put Echo in my house and let that say, hey, I'm your on-demand coach. How are you doing? I saw your sugar's 60. So that's the direction we're going. It's not where we're at yet, but that's what this leads to. It's interventional, actionable data communicated the way that a member does. Yes?
So I imagine that a lot of your successful stories, that people have been self-selected to, I mean, they're already motivated to keep their disease process, or, there's some sort of motivation that they have. How have you been able to increase the people who find this technology or this form scary or too much oversight, or they're just not motivated?
It's a great question. Was, if you guys didn't hear, do people self-select? So yes, obviously you find these stories. This wouldn't be every member, and they're great. Anecdotes are great. You don't build programs on anecdotes, but anecdotes certainly do help. That's what the compliance number, I don't know if you saw the number that Mike had on the slide. It was on the right side. Compliance has gone up 28%, and that was honestly the data. You couldn't see the footnote, but that was actually just in the first year of the program. And just like this gentleman asked about the communication strategy, we literally drop shipped devices and just waited to see what would happen. We thought we'd get calls from the state, right? I mean, I remember your CEO being concerned that the governor was going to call and say, you guys are changing the benefit. I can't believe it. We had about a 6% opt-out rate in the first 3 months, either because people are apathetic or because people like the program. But what we're using is actual true behavioral change theorem. So you guys follow Dan Ariely? Is that a name that rings true? Predictably Irrational is one of his books. And the point is, people are prone not to do anything, right? So we used that theory to do an opt-out program. We also found that compliance went up, to answer your question, without doing anything, and the answer is probably Big Brother effect. People knew that people were looking over their shoulder. You actually heard Lydia say it positively. One of our slides in our BD decks actually says, what if Big Brother was actually the Big Brother we all wanted, right? The Big Brother that finishes your sentences, finishes your fights, goes through life in front of you. I didn't have a big brother, so my cousin is my big brother. We always talk about the George Orwell 1984 Big Brother, right? Negatively. And our point at Envolve is, and Marianne's probably laughing because I love this analogy, what if Big Brother is the really good Big Brother? So that's honestly what we think is happening. We don't know. And honestly, I hope we're all humble enough to say we don't know sometimes. We found compliance went up 28% with zero intervention. That was before coaches' calls. That's before education. And we think a 30% uptick in checking is some people who weren't realize, oh, I guess my health plan's looking. Maybe I ought to do what I should do. That's why we, by the way, have speed cameras out here, right? Right? The stoplight cameras, that's why we audit taxes, right? It allows people to do what they should have been doing all along. Yes, sir?
What are you going to incorporate in oral health intervention?
Rural health or oral health? I don't know that we have a specific plan for that right now within our diabetic program. We have a huge dental program, and they are relatively new. It's probably one of the newer Envolve family companies. We just started a dental health program, so we were actually outsourcing that for years and years and years, and they have just come on board, and so that is one of probably the last integration efforts we have from a company standpoint. So they're not in the On.Demand program as of yet because they're still getting their feet wet within Centene, but I think that's exactly where we need to go next.
We did the drop ship to all the members. The members did not engage at all. They were just calling and saying, get this, or just get it off.
We had, his question was, what do we do? Yeah, so we put a number in there, hey, this is the new program. It's an opt-out, right? You have to call to opt out. Yeah, and we basically had a number. If you don't want to be a part of the program because it's Monday, because you don't like us, because you're wearing a blue shirt, we don't care, you can opt out within 24 hours. And that was that initial 6% opt-out we got, so 94%. Now, that was informed. We made 500 provocative calls and said, hey, we're about to launch this program in Mississippi. This is what it looks like. We'll be tracking your data and sending you test strips. Would you want to be a part of this? and 95.5% said yes. And that gave us the power and the stance to say, hey, we're just going to do an opt-out. But yes, the idea is we basically said, hey, the meter's yours, don't send it back. Thanks for everything. And honestly, what's funny is since that time, we've had many of those members come back on as they figured out, hey, this is a help, right? I don't have to go to the pharmacist anymore.
Specifically for the drop shipping strips, can you talk a little bit about the business case that you developed? Because as I'm sure you're well aware, drop shipping strips is not a traditional MCO practice.
That's right. Yeah.
So talk to me a little bit about how you.
Sure. Mike might, from a pharmacy standpoint, certainly, so jump in if you have a
Sure.
question. But the idea was honestly initially not to save fraud, waste, and abuse money. That was not. If that was the initial program, I would have never got this off the ground. Michael wouldn't have accepted it. My leadership would have never let me launch it. The idea was, hey, I want to put actionable, real-time clinical data at the hands of our case managers and disease managers. Help me do that. That's a story that sold, right? It's Lydia and Amanda. It's that lady I told you who was going to the ER. What we found was that test strip utilization, fraud, waste, and abuse went down 69%. Because people were no longer getting access to those 2-box benefit packages they got every month. And people said, well, do you think they were selling them? I said, I don't care. I don't care if they're selling them. I don't care if they're stocking them in their closet. I don't care if their grandma was using them. I don't care. My point is, we have a managed care organization. We shouldn't shy, right, away from that. Just like we don't allow people to get MRIs because their back hurts. They have to go through prior auth. We said, hey, if they need test strips, let's give them test strips. Let's give them 1,000 test strips. But if they don't need test strips, let's not give them any more test strips. So it was honestly, not necessarily the icing on the cake, it's probably a poor moniker, but it was something we found after the fact.
Sure, it was just an opportunity that presented itself when we were going through the whole process change.
So we found there was good money spent, but we were willing to invest anyway. So just to keep you guys on time, we'll probably wrap things up, but really appreciate your time. Thank you guys so much for joining me up here, and we'll be around afterwards.